Switch to English, just to prove that I can also speak English. The first presentation will be delivered by Professor Hashimoto. The floor is yours.
スライドお願いいたします。
Please have the slides up. Please have the PowerPoints up. How come slides are not coming up? The people in charge, please have my slides up.
ありがとうございます。
Well, thank you very much. I'd like to talk about the quality of medical care and medical service delivery system. The contents, this is the part 3 of the Lancet series. Professor Ikegami and myself served as co-lead authors for the part 3, and other scholars and researchers cooperated. Thank you very much. Overall, I'd like to give you the overall viewpoint. The Japan's healthcare delivery systems, we find strengths and there are weaknesses. So I will make the report in that way. Strengths, Professor Shibuya has already mentioned the highly secured access and equity. That is the strength according to our analysis. Irrespective of income, medical access is quite managed in an equitable way. That is a strength. However, there are problems, weaknesses. Hitherto, worldwide, medical expense was suppressed, and we tried to maintain the medical level. So in that sense, we were successful in that. However, because of the tight control of cost that was very much emphasized, the healthcare delivery system side did not get much policy attention. And approaches and programs were inferior in that aspect. And because of that, problem becomes in the primary care service area. Compared with the U.S. and other countries, there is a quality problem. Later on, I'd like to talk about it. And why did these problems come about? It's not simply a lack of financial resources. The lack of governance in the medical specialty body for quality and human capital development. The specialty bodies and the local governments, what is the governance for contributing to the healthcare system? Accountability and governance were not very clear, and that is the real cause of the weaknesses. First of all, we start from the strengths. This slide shows you the public coverage to total health expenditure, and source is OECD Health Data 2010. Out of the health expenditure, total health expenditure, social security, tax, and other total health expenditures, public coverage proportion is shown. The red bar is Japan. More than 80% of the public coverage is more than 80% to total health expenditure. So amongst the OECD countries, Japan ranks one of the highest. Therefore, there is no financial catastrophe occurring to the household because of the payment of the medical fees. Also, we have analyzed based upon the consumption data, and the health ministry had the data on the house expenditure, for example, the status of health and needs for medical treatment. Against that needs, how much response is given? It is regarded, it is called horizontal equity. So high public coverage of expenditure with horizontal equity was found. The level of horizontal equity is as high as that of general practitioner in the UK. In UK, there is a general practitioner system, and access equity is ensured in Japan as a result of analysis. Next slide. Also, talking about the medical quality, we conducted various comparisons regarding available data. Usually people say that the medical quality in Japan is poor, where U.S. medical quality is extremely high. But as a result of the analysis, when it comes to the high technology care outcome, Japanese care was as good as those reported in other developed countries. We attained high level of outcome of high-tech care. For example, the esophagectomy or hepatectomy and cardiovascular surgeries. Of course, high-risk operations are involved, but they show excellent outcomes in terms of post-operative mortalities. Also, Lancet side conducted in 28 the survival of patients with colon and breast cancers was reported as good as those reported in the U.S. and European countries. Japan ranks rather high in this regard. Next slide. On the other hand, so high-tech advanced care quality is ensured to a certain extent, but the blind spot was found in a primary care area. So we looked into the Japanese National Health and Nutrition Survey run by Health and Ministry and U.S. National Health and Nutrition Examination Survey. We compared these two data, and then hypertension, hyperlipidemia, high cholesterol. In these disease areas, effective coverage of hypertension and hyperlipidemia was lower in Japan compared to that in the U.S., although Japan has the universal insurance system. So there are more people uncovered or not having the treatment. Amongst those who are receiving treatment, the target blood pressure control or cholesterol control is not achieved compared with the United States. The target level, achievement level is lower in Japan. So as I said, we have the universal insurance system, and we have better access to health care. In a country like that, Japan, compared with the United States, where there is no universal health insurance system, the result was low in Japan. We were shocked. We looked into the possible reasons. One is that in our country, primary care is not positioned firmly as a system. For example, the general practitioner or a home doctor is not given as a subspecialty. General medicine is not given a subspecialty. Another problem is that in the medical insurance, medical checkup, preventive service is not covered by insurance. It is covered by other types of services. So preventive medicine and the treatment, between the two, there is a lack of coordination. So that is what we have conjectured as the possible cause of the poor quality of medicine. However, the new national screening program was launched since 2008, and probably this situation may have been improved. We need to further identify the situation. So there was certain imbalance. High-tech medical care, very high quality, but primary care quality was bad. What was the reason for the imbalance? One of the reasons is the distribution of doctors. There is not an equal distribution of doctors. This slide shows you the number of subspecialty doctors in comparison with the U.S. Number of doctors belonging to subspecialty in relation to population. Slide towards the left. The highest bar, that is the neurosurgeon. Per population, Japanese doctors, we have 3 times more doctors than in the United States. But go to the right-hand side. Pediatrics, OBGY, per population, Japanese doctors are fewer. So there is imbalance in distribution of doctors. Next slide, please. So as I explained, in terms of the number of doctors, overall, it is said that we have a fewer number of doctors, but if you look into the details, in some areas there are too many doctors, and in other areas there are too few doctors. So there is a mismatch of distribution. There are certain needed medical care, and then there are certain human capacity to work in that. So there is a mismatch between supply and demand of a healthcare resource. This mismatch is something that we have to overcome going forward. Why did this happen? I think this comes from how doctors are trained in Japan. This is the salient point for further reform. As you know, in Japan, university hospitals take the central play in training doctors. That has been the case in the past until now. But in the case of primary care, especially community-based, clinic-based primary care, and people responsible for continuous and sustainable primary care in nurturing such human resources, Japanese universities were not responding to the needs of the society in Japan. The last slide, please. So this is the concluding slide. Delivery of healthcare needs structural reform. The worldwide, we have a fantastic access with equality to medical care, and this is something that we have to continue. But there are certain problems, as I noted on this screen. Mismatched human capital development and healthcare delivery. And there is a mismatch in medical resources. So there are societal needs, and then subspecialty groups, and the governmental side lacks governance and accountability in providing such human resources to respond to the societal needs. That kind of reform is going to be needed going forward. How can we do that in concrete way? I'd like to wait for the discussion in the afternoon. So I wanted to provide the food for thought for the discussion in the afternoon. Thank you very much.
Thank you very much. I think this was a very important research. First of all, the concept of quality is not a simple concept. There are various aspects and multiple definitions. It's difficult to have one uniform decision, and therefore the results would differ on how depending on the means of evaluation. So in Lancet Japan series, new data is being provided to highlight the advantages in terms of quality of Japanese health service as well as the disadvantages. And this paper has made a great contribution to that extent. And next, this is yet another important issue. In the aging society of Japan, elderly's health service is a very big challenge. Professor Tamiya, please. Thank you very much. My name is Tamiya of University of Tsukuba. I would like to talk about the elderly's problem, focusing on the Lancet paper. Very briefly, let me begin with the explanation of the backdrop. This black line is very familiar to you. The Japanese curve is rapidly rising. Japan is experiencing the aging that will be experienced by other countries in 100 years by only 20 years. And therefore, other countries are following the same track. Could you click to the next one? Yes, please go ahead. And 12% goal plan was made based upon tax financing and family caring. But thereafter, aging has gone up very rapidly, and therefore the system became not sustainable. So public mandated long-term care insurance system was introduced, and this is the focus of the paper. But for the first time in the world, Japan launched the mandatory public long-term care system in 2000. And 10 years after, the elderly's population accounted for 23%, the highest in the world. And we've discovered many challenges in the past 10 years. And then came the Great East Japan earthquake. And as was indicated, 23% was the percentage of elderlies in 2010. And then, could you go ahead? Please move forward. Click, please. Thank you. These are the percentages of elderlies in the affected areas, more than 30%. So this would be the average of 2030 in Japan. Last week, I went to Minami Sanriku. I had an opportunity to visit an affected area. This was a photograph taken. Now, I was only given this opportunity after so many months, but everything had been wiped out. And it was a devastating scene. But I had the opportunity to talk with the residents of Minami Sanriku, and against the aging, which is most advanced in the world, as they try to build their town from scratch, they were very much motivated to build the state-of-the-art village community. And Japan's universal health insurance system has gone through various trials and errors, and I think it's a good timing to review and do some stock taking. And the details are indicated in the Lancet Japan series, but let me go ahead to the next slide. I talked about the aging of the society, but the drastic family structure and family structure change is what needs to be pointed out when we discuss universal insurance system. Originally, the Japanese community was based upon family system, but we now have single-member households as well as couple-only elderly households. But even with this increase in these households and decline in family care, if we compare ourselves to other countries, the elderly persons living with family members account for a higher percentage than other countries. And socialization of care is a new concept that has been introduced with the long-term care insurance when everything was based on family care. And these are empirical-based data. First, we were able to have access to the national level data based upon interview survey, and we were able to compare pre-long-term care insurance when family care was the basis, and after the introduction, when people became eligible to enjoy various services with regards to disabilities, and the number of users and outcomes have been compared. This indicates the increase in the number of use. It was only 50% prior to the introduction, and the number of services used was very small, but as LTCI was introduced, a huge number of people began to make use of the insurance service. And we targeted mainly the community-based elderlies in need of care, and 80% are using this service. That represents the fact that socialization of care has progressed. People used to only provide such care within the family, but the professional or experts have intervened. And with the introduction of care managers, we have a system called care managers, which is non-existent in other countries. And it's not just the family cares, but care managers who are experts conducting the assessment and who make the care plan. And this is one of the greatest achievements through long-term care insurance. And at the time of the earthquake, care managers were quite active, and each person had their assigned care manager, as mentioned by Professor Hashimoto, which had proven to be very effective. And although it's indicated in the text, the service spread, and daycare is used by 6.5%, a very high percentage of the elderlies, and many family members would have been relieved by care work. But let us look at the usage by income bracket. Yes, the total use is increasing, but in 2001, the high-income household represented in green is high. There's a statistical significant difference, and that difference becomes even larger in 2004. This is the percentage of those who are using service. So it seems that the curve between 1 and 04 is flat, but the number of users has been drastically increasing. So please do not be misled. This divides the household into 3 income brackets. Now, especially the high-income households are using this more actively than the low-income households. then not just the statistics, but what about the subjective impression of those recipients? Have they really felt that they are being treated with dignity, and have their family members been relieved of the burden? Now, the interview survey had only limited items, but within the limited constraints, we try to look at the subjective health status and the instrumental activities of daily living as outcome indices, and how these indices have changed before and after the introduction of long-term care insurance. Now, we did control as for statistical comparison, but unfortunately, we were not able to find any statistically significant change in comparison of pre and post LTCI. Then what about the impact to family cares? We use these indices such as subjective health status and decrease in hours of informal care, but we were not able to find any change. However, I talked about the day's service. It was truly possible to reduce the number of care hours, and those who have been relieved, some of them have been able to begin to work. So this has been a big positive impact from the long-term care insurance system. However, this is on page 76 of the full text, but if we look at the households by income bracket, although the total number of hours of informal care is declining, there has not been significant decline amongst low-income households. And have they been able to socially participate in labor? It's only the high-income households whose family members have re-entered into the labor markets. And therefore, that's an area where more improvement is necessary. And high-income earners are being able to participate in the labor market because of work-life balance. But work-life balance is not spread to all households, and in terms of opportunity cost, maybe the low-income earners didn't think that entering into the labor market is worthy of that. So there has been this major gap depending on the income levels of these households, which was an important conclusion that we found as a result of this research. There are many details that I wish to point out, but very broadly, these are the points that long-term care insurance were able to achieve. First, family cares had been the main caregivers, but socialization has progressed, and that had led to more users using the service. And originally, there had been concerns over third parties entering and intervening into care, which was originally family-oriented, but there has been positive impact. And care manager consults to each elderly, and we were able to establish such professional occupation, as mentioned by Professor Hashimoto. This is an action being sought in the area of physicians and medical services, but so far in the world of physicians, this was not able to be done. But in the area of care insurance, we were able to achieve this ahead of health insurance, and we hear that the same system has now been introduced in Germany. There's the problem of burden of care managers, but yet, we think that it was a major leap forward that we were able to establish these people as an occupation. But their situation is not without challenges. First of all, the income gap. And the recipient's subjective evaluation, it has not changed. The number of hours used is increasing, but first and foremost, the objective was to reduce the burden of the caregivers, and that had been achieved. However, service to the caregivers is not offered in the Japanese system. Other OECD countries do have systems to provide services to caregivers themselves, and not just the elderly, but that is lacking in Japan. So not only family cares, we talked about community care as well. the evaluation or remuneration to the caregivers at large, not just family carers but community caregivers as well, should be established, and that has been exposed as a result of this analysis. And also the income gap, especially there has been a difference in labor participation by income, and this will have to be dealt with as a combination with other policy areas, but there should be debate. And very briefly on institution-based care. Family structure has changed. There are no family members whom they can depend on, so facility-based care is necessary. 400,000 people are on the wait list in recent years. So how can we deal with this backlog? This is another major issue. And as an institution and regime, in comparison to Germany and other countries, the coverage is wide and the service offered is quite generous. But to what extent, what improvements can be made? Revision of the long-term care insurance is now a subject matter, but we should rethink what could be improved. And that concludes my presentation. Hopefully this will lead to the next discussion. Thank you very much. Professor Tamiya, thank you very much. Again, this is a very important issue. In the end, there are policies to tackle aging of the Japanese society, and what impacts are being given as a result of the policies. Scientific analysis is being done. Policy evaluation is not easy, and there have been so far very few examples of scientific evaluation of such policy impact, and this will be a landmark study in this kind of area. Next, we will hear from Professor Naoki Ikegami of Keio University. He will speak on the sustainability of universal coverage facing a crisis. Now 50 years have passed, and it's entered into the Middle Age. So why is it a challenge, and what should be done to change the universal coverage system? Thank you.
The slide is already shown. So universal coverage is facing a crisis. So from a sense of crisis, I would like to make my presentation. This is the second paper in Lancet for your reference. Going on to the next slide. Health insurance. Let me start by talking about the structure of the health insurance. The characteristic of healthcare is that no one knows when you'll become ill or how much money would become necessary. And so you would pay premium while you are healthy and receive benefits from insurance when necessary, once you become ill. So that's the principle that is established. And there are two factors that decide the premium rates. One is how often does the insured suffer illness and to what extent receive benefit. And the other factor is how much services are delivered by physicians and at what price. In Japan, the government controls the price and the coverage by the nationally uniform fee schedule system. And thanks to that system, we're able to contain healthcare costs and contain the premium rate increase. Next slide. So this shows the difference between the private and the social or the public health insurance system. It would be easy to categorize into these two different categories. Private insurance sets premiums based on the risk of illness. It is like the fire insurance. There are higher rates set for wooden houses than for concrete houses because they are more prone to fire. And if this same principle is applied, the premium rates will rise with aging. By the way, in Singapore, this is a social insurance, but the premium rates increase with age. And people above the age of 85 years old are not accepted to be enrolled. In other words, if you know that the house will be prone to fire, the fire insurance policies cannot provide coverage. So, on the other hand, social insurance premiums are set based on the ability to pay, depending on the income, in other words. And the services are equally provided regardless of the premium rate paid. So, even if you are healthy, you need to enroll in an insurance plan. It has to be a mandatory enrollment system to invite healthy people to pay. And the basic principle would be mutual aid and solidarity among the insured. That makes possible such a social insurance. But in the case of Japan, the range of and the scope of mutual aid and solidarity depends on the workplace. For example, I am an employee of the Keio University, so a workplace such as that, or a residential area such as this place is located in Shibuya Ward, so that would be the limit of the scope. So against this backdrop, how has this relatively equitable system been achieved? For example, the Keio University that I belong to, or this Shibuya Ward, compared to other areas or workplaces, income level is high and there are relatively high portion of young enrollees, so with a low risk. So with these different income levels and risks, how has an equitable system been achieved? For disparity in income, this has been adjusted by tax subsidies. For example, to National Health Insurance Association, NHIA, for SME company employees, there is 16.4% of benefit spending subsidized by tax. And for CHI, Citizens Health Insurance, there's a tax subsidy of approximately half of the healthcare expenditure. And for municipalities with high average income, the subsidy is 40%, while that of lower municipalities is up to 80%. Another point is that the equalization for later elders' medical expenditure is achieved by a combination of tax subsidies and contributions mandatory from insurance plans and other tiers. From ages 65 to 74, there is contribution from insurance plan with smaller proportion of enrollees in this age group to those with a larger proportion. And for those 75 years and above, 90% of expenditures are covered by tax as well as contribution from other tier insurance plans. This mechanism is illustrated here in this schema. First of all, I would like to refer to the 3 pillars on the left. To the very left, it shows the insurance system for public servants as well as large company employees. Employer would bear 1/2 of the expenditure and 1/2 by the salaried workers. So they are self-sustained financially. And the middle pillar is the insurance system for SME employees called NHIA, National Health Insurance Association. This is one association. Because of the lower income level of small, medium-sized company employees, 16.4% tax revenue subsidizes the expenditure. And the third pillar, self-employed insurance system, 1/2 of the expenditure is covered by the government tax revenue. So by different municipalities and by different companies, there are these different associations. So there are a total of more than 3,000 insurance plans. So for the late elderly's health insurance in 2008, an independent system was established. So once you reach 75 years old and above, even if you belong to other insurance plans, you have to withdraw from that and sign up for this insurance system. And half comes from tax revenue and 40% comes from contribution from the other tiers insurance plans. Next. So disparities have to be adjusted for equity. Of course, this has been sustained to a certain extent, but still there are disparities amongst different insurance plans. The first tier, society-managed health insurance, SMHI. Among these different insurance societies, there's a big disparity of premium rates. And 3 to 9% range, which means threefold disparity of premium rates based on the income level. And there are many young enrollees. There's maybe 3%, and on the other hand, there may be 9%. And the third tier, CHI, Citizens Health Insurance, there's also a wider disparity in premium rates. For me, this is a serious issue. If a salaried worker retires and moves to a community-based insurance plan, then the premium becomes threefold. And now I live in Tokyo, but if I had relocated to an underpopulated area, the disparity will become even larger. This means the reason is that the employer no longer pays, and also premiums are calculated not only on salary but other sources of income. In other words, employee-based insurance, the premium rate is set only by salary but not for CHI. And additional premium must be paid to cover the spouse. For the employee-based insurance, there's no difference, but for the CHI, the community-based citizens health insurance, additional premium has to be paid for the spouse. So the adjustment, conventional adjustments have reached its limits. The disparity among insurance plans is expected to increase. Increase in irregular and part-time employees will lead to more people enrolling in the NHIA and CHI, and there will be increase in the depopulation of some communities, and there would be increase in the percentage health expenditures paid by tax revenue. But you cannot increase the subsidy portion by the tax revenue. That would be very difficult. Twice the level of debt of GDP, and so also reconstruction funds have to be secured after the disaster. So because the CHI premium rate is so high, it is estimated that 1.3 million people are uninsured. This excludes the welfare recipients exempt from compulsory enrollment. So these uninsured people already have a certain level of income, but nevertheless uninsured. And also 30% co-payment and also the high premium rate of the citizens' health insurance discourages enrollment. And also the fragmentation into 3,500 insurance plan in itself is inefficient. This is my final slide. The impact of the disaster on universal coverage. The CHI in hard-hit municipalities will be facing an even more difficult situation. The income decreases in those enrolled, resulting in decrease in premium revenue. And there will be relocation of those with relatively high income away from the hard-hit municipalities, further decreasing the revenue from premiums. And healthcare expenditure increases as illness becomes more serious. And is subsidy from the recovery fund available to improve the financial state of CHI? That's a big problem. The same thing for the society-managed health insurance. If their main office is in the disaster area, their revenue will go down and the income level of the enrollee will go down, but their medical cost will increase. The late elders' health insurance operated at the prefecture level, on the other hand, remains relatively stable. So how are we going to cope with this situation? We'd like to give a reform proposal in the third session. That is all. Thank you.
Thank you very much. The concept and reason of public insurance system was very thoroughly explained. Thank you very much. And in the Japanese regime, why do these disparities occur, and why do these gaps remain, and why do we have to deal with these disparities as important problems? With the analysis and research done by Professor Ikegami, those issues have been clearly unveiled. May I? The temperatures in this room is extremely high, partly because of the need for energy conservation. It is not possible to cool down the room any further, and therefore feel free to take off your jackets, take off your ties, and listen in a relaxed manner. Sorry for that interruption. And those of you who find it noisy with the door open, please let us know. But I think for ventilation purposes and for us to survive, we must keep the door open. Appropriate solution is necessary for complex problems. So next we will proceed to comments. It's 12 or 10 to 12. And if each commentator could spend only 10 minutes each, then we can use the remaining 20 minutes for Q&A with the floor, hopefully.
Ask our commentators to keep their remarks to about 10 minutes each, so that we can be assured to have some time for comments and discussions from the audience, especially since they've been sitting through such a hot physical environment. The first comments are from Dr. Harvey Fineberg. He's president of the Institute of Medicine, and he's the former dean at the Harvard School of Public Health. In other words, when I first started as a faculty member at Harvard, he was my boss.
Thank you very much, Professor Reich. Those of you who know Professor Reich know that no one has ever been his boss.
Tell my wife that.
But I'm one of several deans who served under him at the Harvard School of Public Health. And it is truly a wonderful privilege to be here with many friends and with such a welcoming audience, and particularly on the occasion of this marvelous publication, as has been alluded to and celebrated already, a remarkable collection, to my knowledge, the first dedicated issue in the Lancet to any advanced economy country's health system, and in that sense also represents a very important model for all of us. And I think it's quite interesting to have a commentator, if you will, from the United States and another from Thailand, because we can give quite different perspectives, but both intersecting, interestingly and importantly, on the experience of Japan. And the reason that is possible is that Japan has demonstrated in such a remarkable short period of time, looked at historically, the rapid development and evolution of a successful economy and a successful health system, and at the same time represents at the leading edge many of the challenges and problems that both other industrialized countries and developing countries are currently facing. So we all have a great deal to learn from this set of papers and discussion through this day. I would say that the papers which we've had an opportunity to read in detail, and you've had just a taste from the remarkably excellent presentations of our three discussants this morning, all reflect, in my mind, three key organizational elements. First, every one of the papers is deeply informed and draws from the history of the experience of Japan. They all look back and systematically explain how things came to be the way they are. Secondly, every paper combines original analysis of data with the context, a synthetic appreciation of how that new assessment interacts with other available information to lead to conclusions about the subject. And third, every one of the papers is remarkably candid and forward-looking in assessing the needs and the appropriate responses looking ahead. And from each of these, we can draw lessons of understanding from the history, of enlightenment from the combination of analysis and synthesis, and inspiration from the forward-looking solutions that are advanced in the several papers. I would like to organize my remaining comments under four headings: equity, quality, aging, and evidence. On the question of equity, emphasized perhaps even earlier this morning, but maybe underappreciated, is the importance of the sense of social equity and solidarity, not in the health system only, but in my opinion, in the results that Japan has enjoyed in the health status of its population. And this is because the widespread commitment to education and the very fact of social equity, opportunity, and a sense of social solidarity plays a very critical role in promoting good health and longevity. And this, I think, Japan demonstrates very, very clearly. One of the striking findings in these papers to me is although equity in health was gained in pieces over time, and if you followed Professor Ikegami's clear but complicated presentation about how the insurance system has evolved in multiple parts, with multiple sources of income and support contributing, one of the most startling and important conclusions that he didn't highlight in his presentation but is in the paper is that when you look at all of the sources of financing for all of the insurance schemes, it turns out that Japan has managed to have the burden of support very closely attuned proportionally to income across all income sectors in the population. This is a very important result of equity, but it also highlights, I think, an important challenge looking ahead, and that is when Japan proceeds to reform, simplify, and reorganize the structural changes that will be needed. One result will be that it will expose more clearly the sources of financing that support healthcare. And if it wants to maintain equity of the type it has, it will need to adopt equity itself as a goal, as a part of the structural reform, and not count on it happening by chance. Second, on the questions of quality, it's a very interesting example of international exchange and mutual learning. In the United States today, when people talk about the models for ensuring the quality of health care, the processes that determine the outcomes of care in the course of hospital or outpatient services, one of the models that people point to is the example of companies like Toyota and its lean production system and the ways in which quality is built into the fabric of production, not something added on at the end or managed ex post facto. It's insinuated and assured at every stage of production. But then if you ask, where did Toyota develop lean production? It drew many of the lessons from the instruction and teachings of an American professor, William Edwards Deming, who beginning in the 1950s regularly came to Japan and introduced his concepts of quality improvement, which have been important underpinnings for many industries in both countries for a long time. And so we have a cycle, if you will, a virtuous cycle of exchange. And I have no doubt that this will continue as we learn from one another about ways to practically improve quality. I would like to suggest that in the old concept of what we called the iron triad of objectives for the healthcare system, access, cost, and quality, The old notion was you could choose any two. You can have access and high quality if you don't care what it costs. Or you can save a lot of money and still give a few people very high quality if you don't care about access, and so on. The modern concept, exemplified by the experience of Japan, and I would say in the US, is that these three are not simply coexistent, they are codependent. That the only way to achieve high quality is to do it efficiently, that better quality is cheaper, and that universality enables a system to perform at high quality and at reasonable cost. On aging, I want to make just a brief point. Aging has two distinct aspects. It is aging as a challenge to individuals who are aging, but it is aging as a challenge to a society with a higher and higher proportion of individuals of elderly age. These two are related, but they are distinct. And Japan is, by necessity, leading the way in both of these. The goal for individuals, as exemplified in the paper that we heard, is not simply to add years to life, but to add life to years, to ensure that quality of life, as well as longevity, is the central goal. And finally, on evidence, I want to emphasize the importance of a science-based approach to defining the needs and the opportunities and options for policy improvement in health. This is a matter that is critical for every society to come to grips how exactly to manage to make sure that science and evidence serve as the foundation for policy. But it is especially a challenge in a country, whether it's the US or Japan or others, where political structures do not assure an automatic consensus. And when you especially are in a circumstance where political structures are in some degree in turmoil or in contention, it makes it all the more important to allow science and evidence to drive conclusions for policy. Thank you very much.
Thank you, Harvey. It's always a pleasure to hear your thoughts. I think Dr. Feinberg is one of the deep thinkers on health policy in the United States, and his comments pose particular challenges for health reform in Japan. We turn now to Dr. Sweet, who is a senior advisor for the Ministry of Public Health on Thailand. He is a clear and sharp thinker and speaker on many of these issues, and I look forward to his reflections on the issues in Japan.
Thank you, Michael. And first of all, I would like to thank the host to invite me here to learn. I read through the document and listened to the presentation and comments. It's a great learning day for me. And thanks Professor Tamiya, Ikekami, and Hashimoto for their excellent papers and presentation. I have five short points to share with you here. First is to concur with what Harvey mentioned. In spite of the fact that our Japanese colleague may not be very happy with the issue of equity in terms of equity to pay premium, but we have to accept that this country is one of the most equitable, rich countries in the world. And there was a study to link income inequality in rich country and social problem, all sorts of social problems, including crimes, violence, drugs, even teen pregnancies, and found Japan at the bottom at the bottom means best income inequality and least social problem. Why? You can imagine which country is at the top. The country that spends 17% of their GDP on healthcare. Highest income inequality and highest social problem. It is almost like a straight line relationship. So I would hope that Japan, our Japanese colleague, will lead the world through strong social solidarity and equity spirit. Second, it is quite interesting for me to learn that Japan achieved universal health coverage at $3,500 per capita 50 years ago. 10 years ago, Thailand achieved universal health coverage at about 2,000 or 2,000 plus US dollar per capita. But I think in terms of PPP, purchasing power parity, we may be around the same, I guess. I would like to request Heng and Emin from the WHO and World Bank to do an extensive study around the world to see how countries achieve universal health coverage at which US dollar per capita PPP. And if it is, I expect it is to be around 5,000 to 8,000 US dollar per capita PPP, then we can convince those developing countries who are at this level of income that you should try your best to achieve universal health coverage now. My third point is on the efficient control of healthcare costs in this country. You have a very good healthcare delivery system, good quality, but you spend much less as compared to 17% of GDP on healthcare. I don't know, maybe 10% around here, which is much less, and very good quality of care. I once used, I don't know how you control cost, but I was very surprised, until now still surprised, because one day I visit one of the National Health Insurance Office in Japan and see how they inspect the bill from the clinics. On that day, I visit one of the dentists who audit or inspect the bill sent by his fellow dentists around that area. Thick pile of bill. He finished inspection in less than 10 minutes. So it's just a formality, I feel. Then how can you control the cost? How can you know that this bill is justified? I know you have a very equitable fixed price all around the country, but it may be a fake bill. But you see, they control costs very well. There's much that developed country or country like us should learn from Japan to how to go for fee for service with good cost control. Now I have 2 points to express my concern. First is the problem of the health system. It's not much different from other countries in this region, I think, where hospital and clinics are not differentiated. You can go to the hospital and you see hospital very crowded with outpatient. My country the same. We don't keep patients, outpatient only in the clinics, and hospital mainly appointed patient or inpatient. And you have problem with primary care, GPs, community care. It's the same thing. This may reflect the need. I see Lincoln Chen here. He is not only the president of the China Medical Board, but also chair the commission with Harvard School Public Health Dean, the new boss of Michael, a commission on HRH education in the 21st century, which proposed to reform HRH in health professional education towards more health system responsiveness and community responsiveness, rather than science, only science and technology driven. This brings me to the last point. You are concerned so much on aging. Aging and death are very close. I know to talk about death in East Asian country is more or less a taboo. But we may have to face the fact. I'm originally from China as well. My parents are Chinese. And we don't talk about death at home. But what is the quality of death in this country? If you care about aging, you should care about death. Last year, there was a study done by the Economic Intelligence Unit of the Economist magazine, Quality of Death Index. They ranked 40 countries, mostly rich countries, on the Quality of Death Index. You know, what is Japan in this 40 country rank? 23rd. Below the 50 percentile, 23rd. And they rank under 4 categories. First, basic end-of-life care environment. Japan ranked the 2nd in the world, which means that your healthcare infrastructure or end-of-life care infrastructure are quite good. But how about the cost? The cost you rank 31st out of 40, as bad as the US, which means that it is very expensive to die here in this country. If you want to die, you should go to Alan Lopez. Australia and New Zealand rank the 2nd and the 3rd in the world. I'm talking about country that is closest to Japan. I'm not talking about European, and US is too far away. But US also very expensive. But number 31st in terms of death, cost of death. Now the availability, number 28th, which means that there is no, although the infrastructure there, but they don't serve end-of-life care. How about quality? Number 21st. So still under the 50 percentile. How can the Japanese address more of this issue, in spite of the fact that it may be a taboo here? But it is the fact of life that we have to meet. And if we explore more and do more, we may be able to save a lot of money. Because this cost of end-of-life care mainly go into healthcare cost. I was informed that 17% of the GDP per capita, health expense in the US, mostly go to the last 6 months of life. If we shorten our life by 6 months and we gain 12% of the GDP back, we may be much better off. We may be, living much happily with less than 6 months of life. We have to be very careful. Yesterday, I chaired a meeting on Alzheimer. On my left side is an 80-year-old chairman of the Senior Citizen Council. On my right side is a 70-year-old senior economist. This man raised his hand and said, "Hey, if I'm at the non-functional Alzheimer situation, don't do anything to me. Don't keep me in the nursing home or anything. Let me die peacefully at home. And don't do anything. Don't pay any attention. Because it's no quality of life while living." 80 years old, medical doctor. The economists share the same thing. And after the meeting, they both prepare to write the living will to ensure that no one, do badly to them when they are close to death. So my final word is that we must be very careful not to medicalize elderly, not to medicalize Alzheimer, and not to medicalize death. Thank you.
Thank you, Dr. Sweet. I think your two final points are really important. Keeping a regional perspective on how Japan is doing, and secondly, keeping an understanding of the processes of approaching death as part of your thinking about quality of life and the healthcare system. So we have time now for discussion and comments from the floor. And so there are microphones in front of you.
If you push the button on the microphone installed on your desks, the microphone will turn on. Please identify yourself and affiliation when you make a comment or ask a question very briefly. And please finish your comments or questions within 2 or 3 minutes. Then we may be able to entertain 5 or 6 comments. And after we collect 5 or 6 comments, then we will then ask the commentators to respond briefly. And with that, we will conclude the session. Those of you who wish to speak out, please raise your hand. I see one hand, 1, 2, 3, 4. Yes, the floor is yours.
I'm Yokokura. In the first session and the second session too, I have a number of comments to make. After the Great East Japan earthquake, the healthcare relief, how was it conducted? I felt after the disaster, the strong partnerships amongst the healthcare personnel. The JMA organized the JMAT team. 1,600 teams, more than 6,000 healthcare providers gathered to go to the affected regions. And after the ultra-acute care 1 week post-disaster and beyond, the care was provided at that stage, and nationwide such volunteers gathered, and so there was a strong partnership amongst the healthcare workers demonstrated. That's one point. And DMAT, in other words, the disaster relief teams go around to the affected areas, and there are such teams organized by major hospitals. Immediately after the disaster, they will go into the affected area. As Mr. Tanaka said, the Red Cross group, the DMAT team will go there, and there are other affected regions that are not reached by the DMAT team. This is the largest disaster, the first time in 80 years, and so the commanding lines in the affected area was very difficult to establish, but there was some improvement after 2 weeks or so. And the second point is that in session 2, there was mention from Professor Hashimoto that hypercholesterolemia patients, there are many people who are left untreated for hypertension and hypercholesterolemia. Of course, if they're not treated, the rate of arteriosclerosis may rise, but that is not true. There is insufficient primary care activities. Whether it is related to that, I don't think we can be conclusive just based upon this data. So that was my question. And finally, one point, the cancer checkup also is very low. But the detection of early stage of cancer is top class in the world. So we have good capacity in the communities, in the region. An additional comment. Thank you very much.
Tim Evans.
Tim Evans? Next comment. Thank you very much. Koyama, 6-year student of Tokyo University. I was told I'm the second person. Please focus to one point only. Don't contain several questions. May I ask you a question? Yes, that is fine. Professor Tamiya, in her presentation, I found that care managers increased. and the specific services are being provided. That is now possible. And still, the subjective or objective indicators of services did not improve. Why was it not improved? And if possible, the care providers and so forth, their income is very low. That is one problem. The big amount of tax money is put into, and yet what is lacking? Why is it that the workers do not receive proper payment? Thank you.
3番目、Tim
Evans.
Tim,
Yes,
please.
thank you. Thank you very much. The paper 2 suggests that the rate of out-of-pocket payments has very low levels of impoverishment from healthcare payments in Japan relative to other countries. But paper 3 concludes that high levels of impoverishment from healthcare spending are a problem that needs to be addressed. And I'm wondering if that discrepancy between those two papers in what seems to be different conclusions can be explained. Secondly, I'm wondering, in the context of long-term care, there's no mention in that paper of a problem that's found in many other countries that are facing problems of caring for the aging, which relate to multimorbidity and polypharmacy, and the problems of care coordination for those types of populations. I'm wondering if this is a problem here in Japan or not.
Thank you. 4番目はこちらの方で、はい、お願いします。
The fourth person over here, please state your name and affiliation, please. I am Matsumoto and also director of the Public Health Center. After the presentation of Professor Hashimoto, like JMA, the high incidence of hypertension and hypercholesterolemia, we conduct the health survey. We cannot be conclusive that the incidence is high. And also primary care, you said that there is lack. But what is necessary is, rather than primary care, the lack of family physicians, because there's no cushion of family care practice, people go to the large hospitals and go to the pediatrics ward, and the pediatricians are facing shortage, so they are fatigued. So in the university, they have a training system for subspecialty, and so even if you have just one pediatrics ward opening up, it's not enough. What is your comment?
コメントありがとうございました。
That was a comment from the public health office. Can I receive one or two more questions or comments? Yes, please. Thank you very much. Taniguchi from World Bank. It's not directly related with the World Bank, but there was a mention about the health cost. Say 5%, 10% of cost is collected, but how are you collecting? There is a collection cost and the collection efficiency. Depending upon that, the major corporations are doing rather well because they deduct it from their salary and the premium is collected. And if an individual is given the chore of payment, then the rate of collection may go down. So eventually, when you build a system, what is your idea about the collection cost and collection efficiency?
I see a hand of a lady sat at the center. Please push the microphone. Thank you very much. My name is Hayashi. So far, the gap in medical services, the university clinic department system based upon rotation was trying to ensure the medical experts in each region, but this system is no longer functioning most recently. Do you have any analysis or conclusion? Yes, the university clinical department system's advantage and disadvantage. And there had been this had served as an insurance, and in terms of allocation or distribution of physicians.
So, of course, please comment on whichever question you would like to comment on. I would like to ask the commentators. I would give 3 minutes to each of you to respond. Starting from paper 2 or paper 3.
先ほどのプライマリーケアというふうな問題について
With regards to primary care, as you have said, the family doctor has system or to establish a specialist called family doctor, that is not the enough solution. And Dr. Hasuit talked about this in the Lancet. The Medical Education Committee issued a report, and this is an issue reported in that report as well.
今我々
Basically, what we have to do now in the field of medical education, there are certain issues and challenges. Creating a new subspecialty or a medical knowledge required of that subspecialty must be upgraded. No, that is not the problem. The basic thing is the social needs. As was mentioned, the hyperlipidemia is very prevalent. And how do we respond effectively to such needs in the society? And how do we nurture and train human resources to cater for that? It is not simply nurturing doctors, creating a system, and the non-doctors included, effective human resources must be developed. Incidentally, all right, time is up. Okay.
大学の先生は一般的に喋りたい人。
University professors always continue to talk when they occupy the microphone, but Professor Tamiya, I'll try to be brief. First of all, care manager, medical department student, being interested in care manager. I'm happy to hear that. It's a very busy occupation, and they have to deal with several patients, and they cannot offer enough service for each recipient. And consultation training is not thorough because the system has been only started very recently. And also, the welfare is the profession, and they are not professionals of medical services requirements or assessment. So, first of all, care managers connecting their profession with the medical experts and also the total life of the recipient, some kind of linkage is necessary. We need to establish an environment where it would make it easier for care managers to work, and more robust support would be necessary, and we're now beginning to see regional centers that provide service to care managers, so hopefully the situation will improve. And in terms of wage paid to caregivers, this is a major labor policy, so it's difficult to respond. But one thing I was concerned, even when the price for service goes up slightly, that doesn't mean that the facility will be able to raise the pay they pay to their caregivers, because the cost of the centers is high, and also the price paid for service would change depending on the premium of long-term care insurance. So they cannot just increase the pay just because in 1 year, as a result of the revision, the price of the service had gone up, because it may go down in the future. And you talked about drugs, pharmaceuticals. Yes, it's a very issue, but long-term care insurance is very limited in terms of medication. In the Japanese health insurance system, volume-based drug prescription have been promoted. It's a great difference.
I'll give Harvey and Suit a chance for their final reflections, if they'd like to add anything.
Dr. Suit talked about the end-of-life care, and I would like to respond to his questions. There are issues with regards to end-of-life care in Japan. I agree totally, and I am conducting research in that field as well at this time. But there is one misunderstanding that I would like to correct here. In other words, the cost of end-of-life care is massive. That is a misunderstanding. That is wrong. If you do the survey, 1 month before death, the medical care is only only 3% of the overall healthcare expenditure. The reason is that patients do not go to hospitals to die. Only 6% is discharged due to death, and the inpatient cost is 1/2 of the hospital expenditure. So 3% is a justifiable number. So if you look at the individual, looking at the lifelong healthcare expenditure, it is 20% involved in AOL. But if you look at the cross-sectional populational data, it is only 3% of the total healthcare expenditure. So the need to increase care quality is necessary, but a huge amount of healthcare spending in end of life, that is a misunderstanding. Another is collection cost for premiums. This question was also raised. This is also a big problem. For the late elderly's health insurance system, those people in the lowest income bracket, 350 yen per month is the premium rate. In other words, collection cost is much higher than the actual revenue, but that is not identified as a issue, but at this time, so we have to consider it as an issue. So from a low-income elderlies, how can we collect the premium, or whether it is appropriate to collect from them? This is a big issue in CHI as well. When thinking about collection efficiency, the ID number systems of Social Security to capture the income level at the household level is very important. That would be my suggestion. Thank you.
So we will conclude with opportunity for a reflection from Harvey and then from Suit.
Thank you, Michael. Just one thought as we dive deeper into fixing the health care system and you think about all of those challenges, keep the separation between health and health care in mind. The pathways to protect and preserve and advance Japan's lead in health status is not the same as improving your efficiency and performance of your health system per se. So don't lose focus on the determinants of health, which are apart from all the needed changes for health care.
Suit?
Just one point that we may not have discussed here. Last year, we have around 2 million foreign patients in Thailand. 20% come from Japan. 20%. I was informed that to have a set of medical examination in Japan and pay only 30% of the expense, 70% paid by the insurance, 30% paid out of pocket. But if they go to Bangkok, have the same set of medical examination, the expense of that examination plus the economy class air ticket, plus the living expense, plus one set of 18-hole golfs in Bangkok is lower than the medical expense here. I cannot confirm this. This is by verbal. But you can see many Japanese moving out to get medical care. At the same time, Japan government has signed an agreement with Indonesia and Philippines to receive their nurse into Japan. So this issue of medical trade in health services is being more and more discussed and seriously affect healthcare system in developing countries as well, because my country have to spare rare specialists, not GP like me. They don't want GP like me. They want rare specialists to serve rich country people, 2 million people in my country. And in spite of the fact that Indonesia and Philippines, they are inadequate in their nurse in the rural area, but they are surplus for the whole country because they have limitation, economic limitation to hire them. They send it here as well. You may be able to add more to this, but this is the Japanese situation reflects the situation of human resource for health and patients migration around the world.
はい。私も簡単に
Then, in 1 or 2 minutes, I would like to very briefly point out one lesson I've learned that I regret.
一つの
Healthcare reform is not a transient process. It has to be considered as an infinite process. A transient point of reform to establish a perfect system, and that does not rule out the need for future reform. That's the same for any country. We cannot establish any perfect system. Always, once you overcome one issue, there are always other issues that emerge. So, against the circumstances faced by Japan, there have been accumulation of various challenges that have not been solved, and it is exposed now. So structural change is necessary at this timing, and the hypothesis is proposed in this special series of Lancet. That is the strong message. And whether that is possible or not, of course, depends on the politics and the economy in Japan, and sufficient scientific analysis and assessment. And the third point is that specialists and the public actors are required who can be involved in campaigns. It all depends on these factors, whether it is possible to conduct institutional reform. But to conduct a reform at one point in time, that does not mean it is the end of all reforms. So there is one wish that I would like to express. We hope that we join forces and work hard.
それではロジスティックの件だけ申し上げます。
Thank you very much. In terms of logistics, we are delayed by 5 minutes to close the morning session. So as planned, we would like to resume at 2 o'clock for session 3 in the afternoon. We have identified the current challenges, and there's been various opinions that have been posed already. So now let us turn toward the future. In the next session, we'll be talking about what we should do in the future, and I think we'll be hearing diversity of opinions. We hope to take a lot of time to accommodate discussions. So I look forward to seeing you at 2 o'clock for session 3. We solicit for your cooperation. Thank you very much for your kind attention.
Okay, thank you. Very nice. You are such a very convenient person.
Maya. Maya. I have a new book coming out.
一回下です。
多分、World